Hello, everyone. So now we're going to continue with medication for viral infections. So let me share my screen with you so we can start. So in this chapter, like I mentioned, medication for viral infections, non-HIV. So in this chapter, we're not going to talk about any drug that is related to HIV. Now, regarding antiviral therapy, we don't have a lot of drugs out there due to the fact that viral infections, when they attack the body, they basically get inside our cells in order to multiply. So if I want to treat a viral infection, basically I need to kill those cells that are infected. And depending on the tissue, I can do serious harm to that patient. So basically what we do based on the effects of the disease, we have to outweigh the benefit of producing damage to the patient using antivirals, or we let that viral infection follow its natural course and let the patient's body or immune system defeat it by itself. If we decide to treat the patient, you need to understand overall that all the medications we're going to be talking about, they're going to be stopping viral reproduction inside our cells. Okay, so let's start. The first group of medications are for herpes, for the herpes family. And regarding herpes, here we're going to be talking about simple herpes that affects the genital area, simple herpes that takes the mucosa of the lips or fever blisters, shingles, and chickenpox. So those are the most common diseases caused by the family of herpes or herpes viridae, herpes virus. So the first drug we're going to be talking about is called acyclovir, Sovirax. All this family, we're going to see cyclovir as a common ending. Acyclovir can be used for all members of the herpes virus family. And like I mentioned, herpes simplex of the genitalia. Well, it says here mucocutaneous herpes, but this is a fever blister. And VCV infections, that means chickenpox. So in those three situations, we can use acyclovir to treat them. Regarding the presentation, if we're talking IV, adverse effects is going to be phlebitis. Now, regarding these two other adverse effects, acyclovir is nephrotoxic. It's a medication that is going to be excreted mainly to kidneys. And when this happens, it's going to produce irritation, and that will produce kidney damage and also produces neurotoxicity. Patient will have peripheral neuropathy. They'll be complaining about having the sensation of having ants crawling under the skin, sharp pains, and numbness. When the medication is PO, the adverse effects are going to be MVD, may produce vertigo. Acyclovir is able to cross in a small percentage to the brain, so it can produce dizziness, vertigo. And regarding topical therapy, for the fever blisters, that can produce a stinging sensation. Valacyclovir is a variation of acyclovir, and same thing is to treat herpes zoster, the shingles, herpes simplex in the genitalia, herpes labialis, this is the cold sore or fever blister, and varicella chickenpox. Now, what is the big difference here, or the highlight? Valacyclovir is considered a pro-drug. What is the meaning of this? We mentioned in class that all medications by mouth, they have to go to the stomach, They have to be digested. They go to the intestine. They get absorbed. They go to the liver, and the liver is going to activate the medication in order to start functioning and have a proper effect. All this takes 30 to 1 hour. Prodrugs are medications that are PO, and they can be used on patients that have liver disease, patients that have a decrease in liver function. A prodrug is a medication by mouth that is already activated, and it doesn't depend on the liver to get activated in order to have an effect. So when I have a patient that has liver damage and has a disease, usually the first option from most doctors is to use IV medications. But if I have a medication that is considered a prodrug, then I can give this medication without, getting worried that the liver is going to be unable to activate it, because the medication is already activated. It doesn't need the liver to do that. Another use for valacyclovir is for bleedings, autoimmune bleedings of the skin. Basically, the body attacks the platelets of the body. The antibodies attacks the platelets of the body, and that's going to produce a purpura, skin bleeding. And same thing with hemolytic uremic syndrome. The autoimmune system starts attacking the platelets of the body, and it's going to increase that bleeding that we see on the skin. Anciclovir, same thing, has the cyclovir ending. It's a prodrug, so that means that even if the patient has some type of liver damage, it can be used PO, and has the same effects of cyclovir. That means it can be used for different types of herpes infections. Looking at adverse effects are minimal. PO administration, so that means it will be nausea, vomiting, and diarrhea. Regarding topical drugs, we have penciclovir. Again, you see the cyclovir ending, and we have duconazole. So this will be one exception of the rule of a medication to treat herpes, but without the cyclovir ending. Now with this one, the indications, they're topical medications that has to be used as soon as the patient feels symptoms of herpes in the mucosa of their lips. They don't have to wait for the cold sore to fully bloom in order to start using it. As soon as they have this uncomfortable sensation of burning, then they can start using it. Also, we have herpes infection in the eye. So we have presentation eye drops. So we have ganciclovir. So this is an easy one to identify right away. Cyclovir to treat herpes infection, and trifluridine. And same thing, as soon as the patient has symptoms of that burning sensation, very characteristic of herpes, then they have to start using those drugs. Okay, also we have a cytomegalovirus. This virus is also part of the herpes family. This type of virus is transmitted via body fluids. So in high school, they know it as the kissing disease. This is a disease, a virus that produces mono. And just like the other herpes viruses that belong to this group, once we get it and we treat it, we don't kill the virus. It's gonna remain dormant until when? Until we are immune suppressed, and then it comes out again. So usually the herpes virus or any virus from this family, when we get infected, usually the first stage of the infection is going to be always some type of a skin lesion. That's how they start. if we decide to provide medications to the patient, or if we let that patient fight that virus on its own, that virus, instead of being eliminated 100%, is gonna go dormant in cells that the antibodies are not gonna attack. So usually, herpes virus goes to the nervous system. That's where it remains dormant. Neurons are cells that they don't multiply. So the body knows that if the antibodies attack the neurons, they're gonna get destroyed and there's no cells to replace them. I like the skin. On the skin, we constantly making cells so the body knows, hey, do whatever you need to do, eliminate that virus, we'll make more cells. With a nervous system, it doesn't happen like that. With neurons, it doesn't happen like that. So that's a good place for that virus to remain dormant. And then we are immune suppressed, they jump from that neuron, from the axon to the nearby tissue and produce infections again. And that's where the shingles come from. So if you as a kid had chickenpox, most probably you have the virus dormant in your body. And when you get immune suppressed as you get older, instead of having the chickenpox again, you're gonna have shingles. And usually there's little blisters on the skin, they're very painful. And if you follow the pattern of the blisters, it's always following a nerve. So the most common presentations is on the chest, on the side of the chest. And when you see the blisters, you notice that they follow a rib. Why? Because ribs, they protect the nerves that goes to the chest. So that's a good example and see how those viruses spread every time we get immune suppressed. Ganciclovir, again, we have the cyclovir ending. Also used to treat herpes virus, also for cytomegalovirus, to prevent and treat infections in mono and immune compromised patients. Also is used to protect patients that have organ transplant, HIV infection, or are taking some type of drug to immune suppress their immune system. In other words, patient with autoimmune diseases. So ganciclovir, and keyword here, is one of the few antivirals that we use to prevent herpes infections because they are immune compromised. Immune compromised because they have to take a medication to prevent organ rejection because they have HIV infection, or because they're taking medication to suppress an autoimmune disease. So unfortunately, this is a long-term treatment, and the side effects are gonna be in the bone marrow. So what's gonna happen? We're gonna have granulocytopenia. So that means that the neutrophil, basophil, and eosinophil don't have granules. And these three cells, part of the white blood cell family, they need those granules because inside those granules have chemicals that they use to fight infections. So with ganciclovir, it's gonna take those granules away. The bone marrow will continue making those cells, but without granules. So the neutrophil, the basophil, and eosinophil will not be mature enough to fight a disease. And thrombocytopenia, lack of platelet cells. So the patient is going to have skin bleedings. And we mentioned that the two most common names you're going to be hearing, petechiae and purpura. Also, ganciclovir affects reproductive toxicity, especially on the male patient. So that means that male patients will become infertile due to a low number of spermatozoids. If the medication is PO, then we have nausea, vomit, and diarrhea, because it's a long-term treatment on those patients that are immune suppressed. We need to be careful with the liver dysfunction. And patients have complained of having confusion on the long-term use of ganciclovir. Valganciclovir, ganciclovir, prodrug. So that means if the patient already has some type of liver damage, we can still use it with a very good outcome. Valganciclovir is used for cytomegalovirus in the retina. So the infection is inside the eye. Blindness is one of the symptoms. And is also used for patients to prevent cytomegalovirus infections in patients that had an organ transplant. So again, every time a patient gets an organ from another person, the natural tendency of the body of that patient is to reject that organ. It doesn't belong there. So we need to provide immunosuppressants. I need to suppress that immune system from that patient in order to prevent organ rejection. So beforehand, I know this patient is going to be exposed to any type of infections. So it's very common in those patients that had a heart transplant to get valganciclovir as prophylaxis to prevent a viral infection like cytomegalovirus. And we mentioned, unfortunately, the adverse effect, even though it's a prodrug that is not going to be used in the liver to get activated, still is going to produce effects on the bone marrow, where neutrophils, basophils, and eosinophils, they're not going to have granules. There's going to be a low count of red blood cells, anemia, and a low count of platelets, thrombocytopenia. If the medication is given by mouth, NVD, and unfortunately, this type of medications long-term suppressing the bone marrow can produce cancer of the immune system. Lymphomas will be an example. As an advice regarding the tablets, direct contact with broken tablets should be avoided. So don't touch those type of tablets if they're broken. Make sure that when you handle the prescription, you have gloves. And those broken tablets should be disposed in the same manner as a cytotoxic drug. So you have to, don't just dump it in the sewer system or stuff like that. There's a special protocol in hospitals where they let you know medications that are cytotoxic, medications that are used for chemo, medications that are able to suppress the immune system. They have to be disposed, and they'll let you know where to put those medications. Cytofovir also is a medication to treat cytomegalovirus in the retina on patients with AIDS. So same thing, if you're noticing right now, all those medications, they're gonna produce some type of penia, neutropenia, leukopenia, retinalocytopenia, and so on. Because the target here is the eye, well, the patient's gonna say they have blurry vision or a diminished in their visual acuity. Medications are eliminated by the kidney, so they may have nephrotoxicity. And we mentioned that the follow-up regarding the kidney is BUN and creatinine. Another medication, forscarnet, also very good to treat viral infections. It's up there with ganciclovir. Same thing for CMV retinitis or cytomegalovirus in the retina. Foscarnet is used when the virus is already resistant to all the other cyclovir options that we have. And same thing, it's eliminated by the kidney, so we're going to have nephrotoxicity. Foscarnet has a tendency of doing an electrolyte imbalance regarding sodium, potassium, and calcium. So we need to be careful on changes regarding fluids. If we're talking about sodium, if we're talking about potassium, we have to make sure that we do follow-ups with the heart, EKGs. If we're talking about calcium, then we need to be in close contact with the muscle contractions and so on. Okay, next one is medication for hepatitis. Viral hepatitis, one of the most common liver diseases here in the States. We have 6 types, A, B, C, D, and G. And the ones we follow, or we try to correct, to treat, is B, C, and D, because this is what causes chronic hepatitis. And chronic hepatitis can cause hepatic cancer or cirrhosis. So that's the reason we cannot treat patients with hepatitis B, C, and D, because of those 2 severe outcomes. So regarding hepatitis, cancer hepatitis C, we have 6 genotypes with more than 50 subtypes. So that means that we have more than one variation of hepatitis C. Hepatitis C, the exchange is through blood. And some authors have stated also sexual transmission. Even if the patient has no symptoms, it can also be transmitted. So that's the scary part. Hepatitis C is low, but like I told you, cancer, it will be the outcome. Hepatitis C is the main reason for liver transplants. And like we mentioned, if the patient's going to have a new organ, we need to provide medications to immune suppress the body. Okay, so how do we treat hepatitis C? So one of the main drugs that we give is interferon alpha. And basically, I told you interferon is a protein that is gonna enhance function of the immune system. That's what it does. So interferon basically is a protein that is gonna tell the immune system, hey, this is where the virus is hiding. Come over here. So it's like a beacon. Interferon alpha is gonna identify all the cells in the liver that has the infection, and it's gonna mark them. That way, the immune system is able to identify what cells they need to kill. The advantage of the liver is that it's the only organ that we have that it can regenerate to the original size. So regarding interferons, we have 2 types, alpha, beta, and gamma. And alpha is the one that is used for hepatitis. The medication is IV. We don't have PO. The adverse effects, patient may feel like they have the flu. That means that they feel weak. There's body aches, headache, maybe depression. Like they say over here, depression. And again, those are adverse effects suspected from the use of IV interferon. Severe adverse effects will be thyroid dysfunction, heart damage, heart failure. We already mentioned bone marrow suppression, leukemias, and anemias. Okay, we'll come back to this one. Yes, let me make One quick correction right away. Just give me a minute. Is there? Okay. Okay, now we're gonna jump to antivirals to treat respiratory syncytial virus infections. This infection is a bronchiolitis, not bronchitis. Don't confuse bronchiolitis with bronchitis. Bronchitis is inflammation of the bronchi. Bronchiolitis is inflammation of the bronchiole. And the bronchioles is the breathing part of the lungs. So bronchiolitis is more severe than bronchitis. Bronchitis, the bronchi, is just part of the windpipe. It helps move air from point A to point B. That's it. But bronchiolitis, this is where we find the functional portion of the lungs. This is where we can find the alveoli. And they are together, and we call it alveolar sac. So the bronchioles, that's what they have, or that's the importance of it. That's the functional part of the lungs, and that's where we have gas exchange. Oxygen for carbon dioxide. So if I have an inflammation at the bronchioles, bronchiolitis, the patient cannot breathe. So this is an infection that can kill the patient. The patient go from newborn to 2 years of age. That's their main target for this virus, respiratory syncytial virus. That's the main target. So the medication that we use is ribavirin, and is inhaled. So it's given through an inhaler. We can use a nebulizer. Why? Because again, look at the age of the kids, newborn to 2 years of age. So for them to, swallow a pill, or if we give the presentation PO, it's gonna take way longer to get into the lungs, and by the time it reaches the lungs, it's gonna be less than half the amount we provided. So the best way to give this antiviral is through a nebulizer or inhaler, and it goes directly where the bronchioles are in order to start fighting the inflammation process. The other one that we use for this type of infections, for respiratory syncytial virus infection, is palivizumab. And I told you, I already mentioned in a few chapters already, MAB, mono antibodies. So here we are given monoclonal means one specific type. Monoclonal antibodies, we're given one specific type of antibodies that we already designed to fight the respiratory syncytial virus in this group of patients. This medication is not inhaled or PO, has to be IV. Ribavirin can be also used with sub-Q PEG interferon alpha, for the use of hepatitis C. So ribavirin, and this is something from the last few years, can be used also to treat chronic hepatitis C. We already mentioned aerosol or nebulizer for the kids when they have bronchiolitis. And the adverse effects, unfortunately, yeah, it's going to go to the bone marrow. So we're going to have hemolytic anemia. The red blood cells are going to get destroyed. This medication, ribavirin, is not advised on pregnant patients. Category X is going to cause severe mutations, severe teratogenic changes on the baby and the fetus. On regular patients, they may have flu-like symptoms. Again, they're going to feel weak. They're going to feel without energy, maybe a sore throat. And just like all the others antivirals that we have mentioned so far, they can cause depression. Okay, let's jump to the next group of antivirals. And we have protease inhibitors. Same thing, remember, all antivirals are inhibiting the replication of the virus. So they are inhibiting the replication of viral DNA. So here we have dosprevir and tenofovir. So we have the previr ending, also used for chronic hepatitis C. Because they're new, they're still very, very expensive. Regarding adverse effects, they're more mild than the other ones, but still they're gonna hit the bone marrow. So that means we're gonna have anemias and penias, and they interact with a lot of drugs, unfortunately. And remember, patients with chronic hepatitis C, they're taking other drugs, and when they're interaction with boceprevir and tenofovir, we can have severe drug interactions, diminishing the effects of the other drugs. Regarding hepatitis B, it's a chronic infection also. We can find it a lot in adults. And the problem, like I mentioned before, with viral hepatitis is that they progress to cirrhosis, liver failure, and cancer. Hepatitis C is transmitted via blood and semen, and this is confirmed. Regarding hepatitis C, we have interferon alpha as part of the treatment. So we're going to talk about it. PEG interferon alpha. So again, we have interferon alpha, yes, exactly up here. And then we have specific drugs, lamivudine, adfovir, and teocarvir, tevivudine, and tenofovir. All of them, as adverse effects, they have immune suppression, affecting the bone marrow with penias and anemias. The next viral disease is the influenza or the flu. There's two types, type A and type B. So you have two specific groups with subtypes. And the flu shot that we get each year depends on what type and subtype was more spread the year before that, which one had more cases. So each year we have it's a new flu vaccine. Regarding drugs, we have two types that we're going to talk later. It's just adamantines and neuraminidase. And the CDC advised yearly vaccine to prevent the flu. Regarding the flu, there's two types. We have the inactivated influenza vaccine. This is a nasal spray. Inactivated influenza vaccine is advised only on patients that are immune suppressed by X reason, or pregnant patients if they need it. That's when we're gonna provide that. The rest of us, we're gonna get the regular shot, which is a live attenuated influenza vaccine. That means the virus is alive, but because of the preservatives that we use for the vaccine, that virus is not strong enough to produce a disease. So it's a weak virus. We have to explain to the patient that the virus will take 1 to 2 weeks to provide protection, and the protection is around 6 months to a year, more or less. Serious adverse effects that we may see is the Guillain-Barré syndrome. And Guillain-Barré syndrome is a paralysis of the patient, and it's a progressive paralysis. That means that it's gonna start on the toes and start going up, 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 up. When we have a patient complaining about paralysis that start on the lower extremities, and there's a background of the flu vaccine, we need to act fast because we don't want that paralysis to reach the diaphragm. Unfortunately, that's how they die. They stop breathing. So Guillain-Barré is not exclusive of the flu vaccine. Guillain-Barré can be seen after any type of viral infection. So don't make the connection that flu vaccine equals Guillain-Barré. Any viral infection may produce Guillain-Barré. Regarding the flu vaccine, make sure that the patient doesn't have fever. If that's the case, we tell the patient we cannot provide the vaccine to you. Please return 2 days after your last day of having fever. Once we provide that vaccine, we need to tell the patient that they may have minor illnesses, pain, maybe a little rash around the area where the vaccine was provided. And if we're talking about patients, pediatric patients, we can advise them to provide 1 dose of Tylenol. Now, regarding the vaccines in general, we need to advise not to take the regular vaccine if the patient has egg allergy. The thing is, in order to preserve the virus, we use proteins that are found inside the egg. So if the patient is allergic to egg and we provide the flu vaccine, he's gonna react to those proteins that are helping the virus survive without dying, but not providing enough energy source to produce an allergic reaction, to produce a disease. So again, if the patient has an egg allergy, we don't advise the flu vaccine because of the preservatives that it has. Okay, now regarding medications for the flu, we mentioned there's two groups, neuraminidase inhibitors and adamantines. Adamantines. I know tongue twisters. So the main one, oseltamivir, and as you can see in this family, they have the amivir ending. Oseltamivir can be used for type A and B, and has to be used before 48 hours of symptoms. So if a patient goes see the doctor and they're saying, "Hey, you know what? I don't feel good," and the doctor tells the patient, "You have the flu." In order for oseltamivir to work properly, those symptoms has to be inside that 40-hour window. If not, it's not gonna work. Tamiflu or oseltamivir is not gonna work. So that will be the main highlight regarding oseltamivir. We need to provide it in the first 48 hours of the patient having flu symptoms. Tamiflu can be used for type A and type B. Amantadine, amantadine, are only for type A flu. And regarding amantadine, it's also used, if you remember properly, for Parkinson's disease. Regarding Parkinson's disease, they increase dopamine. There we go. Okay, so that's all for this chapter. Thank you very much for your attention, and I'll be seeing you soon.